Hey guys, you are watching the Medical Forum, and this is Dr. Ishfaq. So today I'm going to talk about a rather important topic. It is upper GI bleeding. Right now, upper GI bleeding is quite important because as junior doctors, house officers, and even if you're not a house officer, you are at a posting where you are the first person in contact. Upper GI bleeding is a acute medical emergency. It is a acute medical emergency. So you need to take steps to find out the cause and then treat the cause, and most importantly, keep the patient alive until you send him to a place where a definitive treatment can be given. So first of all, if a patient presents to you with upper GI bleeding, let me give you a case scenario. I think that will be the best way to learn. So basically, you have a 72-year-old male, right? I'll give you two scenarios. You have a 72-year-old male who is a known patient with ischemic heart disease, who is coming with hematemesis and melena. So you have this as your case. On admission, his blood pressure is 70 by 40. He's pale and he's almost at the verge of collapsing. What do you first do? So basically, in managing any emergencies, you have to go through the ABCD approach: airway, breathing, circulation, disability. Airway, breathing, circulation, and disability. Now, first of all, you should assess his airway. Okay, assess if he's able to maintain the airway. Maintain the airway, and we should target a saturation of more than 94%. If he's not able to, start adding prescribing oxygen, because these patients are having severe anemia. They definitely can't oxygenate tissues, right? Next is the breathing. Check his breathing. If he's breathing well and if his GCS is low, you need to make sure you have to do a definitive airway if indicated, right? Let's say he's still at the verge of collapsing, he's not unconscious. Okay, circulation. So we know obviously that he's hypovolemic. Pulse is so thready that you can't even feel. Then what you do is you immediately put wide bow cannula. You immediately put a wide bow cannula and you take bloods for grouping and cross matching, which is DT, direct testing, grouping and cross matching, and you take bloods for some basic investigations. While you are taking this, meanwhile, parallelly, immediately give him IV crystalloid bolus. You need to give him an IV crystalloid bolus. The ideal choice is normal saline. So you give him a rapid bolus. Basically, you have to take the saline bag and squeeze it, right, to make sure you see a response. If this is not enough, you can give the second bolus. But ideally, blood is the thing which should be given, but grouping takes time. Usually in a well-established blood bank, it takes at least around 30 minutes for things to happen and for you to get the blood to the ward. So what you can do is you can request uncross-matched uncrossed match, group specific blood. Uncross matched, group specific, like if it is B positive, you can still take a B positive uh, which is not cross matched, right? If not, you can take uncross matched O negative blood. Uncross matched O negative blood. This is the one which you can get down in 5 to 10 minutes. So start blood transfusion. So you start blood transfusion rapidly, and basically in large transfusion you need to give blood products in a ratio of 1:1:1. So a red cell concentrate, fresh frozen plasma, and platelets should be given in the ratio of 1:1:1. So what do you call a clinically significant bleed? It is when you have to give more than 4 units of blood. If you have to give more than 4 units of blood, it is called a clinically significant upper GI bleeding, right? So that is how you first start managing. So now what do we know on the evidences, right? On the evidences, if we talk about the evidence, let me zoom in this area. Okay. So when talking about the evidences, this is what you need to know. Now, this patient, I'm not told that he's having CLCD. So we'll assume that this is not variceal. I'll talk about variceal bleeding on another section, another video. We are talking about non-variceal bleeding. What are the causes? Now, this patient has had ischemic heart disease. He might be on antiplatelets. So, antiplatelet induced, antiplatelet induced. He might be having peptic ulcer disease. He might be having a malignancy which had corroded an artery and bleeding, right? He might be having some angiodysplasias. He might be having some angiodysplasias like Osler, Weber, Rendu syndrome. This is also called as hereditary telangiectasia. Hereditary telangiectasia, where they have multiple telangiectasias and AV malformations where it can bleed if they occur in the stomach. Next, now we know that these might be the cause. Next, what we do is, if the bleeding is not stopping, the ideal evidence is in less than 24 hours, you need to schedule a upper GI endoscopy. So you have to either refer to the surgical team or refer to the gastroenterology team. So they will arrange an urgent upper GI endoscopy. So in patients with non-variceal bleeding before endoscopy, one important thing, giving IV erythromycin 250 milligrams infusion. IV erythromycin 250 milligrams as an infusion has proven to show that they will have a better view at endoscopy. Okay, because it has prokinetic action, they will have a better view at endoscopy. So IV erythromycin has an evidence based behind this. Next, what is the drug which has some evidence in non-variceal bleeding? Is IV omeprazole. We usually give an 80 milligrams stat and followed by that 80 milligram per hour infusion. So IV omeprazole 80 milligrams stat and 8 milligram per hour infusion. So you started giving blood, you started giving crystalloids, you're trying to make sure he has a proper blood pressure, and then you are arranging him a urgent upper GI endoscopy. Now arranging this will take time, so meantime you need to keep him clinically stable, you need to keep him hemodynamically stable. So these are the measures you take. Now apart from this, now in patients who are bleeding, taking a full blood count, what is the hemoglobin target we are planning to achieve? So the hemoglobin target is basically less than 7 grams per deciliter. Now this concept is called uh, restrictive transfusion. It's called a restrictive transfusion because hemoglobins above 7 will be a what will happen is that you will be transfusing more red cells that will be diluting the clotting factors, so that your clotting mechanisms will get impaired and the patient will start bleeding again. So that is what we call the restrictive transfusion. And in patients who are having high risk, like ischemic heart disease, like in our patient, you need to keep the hemoglobin above 8 grams per deciliter. So if the hemoglobin is around 8, you don't have to transfuse further. So these are the measures, these are the evidence-based practices. Now, once we arrange an upper GI endoscopy, you can see the ulcers. You can see the ulcers and the bleeding spots. You can see the ulcers and the bleeding spots, and they can be coagulated by bipolar diathermy. Bipolar diathermy, that is the most recommended thing. That is the most recommended device. Next, let's say upper GI endoscopy doesn't show anything, doesn't show evidence of bleeding. Instead, it just only shows evidence of pangastritis. But still patient is having ongoing melena. Patient is having ongoing melena. Now that is a problem. Now what you do is you try other methods. Then you involve other disciplines. You other specialities, because you need to know your limits. You need to know that patient's life is important. If you are reaching a point where you are limited with the options of management, definitely involve other specialties so that you can get through with something. So you can either go for surgical option, you can either go for interventional radiology. So what will the interventional radiologists do? They can do a mesenteric artery angiogram. They can do a mesenteric artery angio, and they can find if there is any bleeding spots, and they can do selective embolization. If that also fails, definitely you need to go for surgical, where you even go until a partial gastrectomy and control the bleeding, right? So let's say there were some bleeding spots and you've stopped the bleeding, and now things have settled. So what do you do is, now you have to give something called the preventive medication. So evidence-based preventive medication shows that you have to give proton pump inhibitors like omeprazole, double dose like 40 milligrams BD for at least 2 weeks, together with a prokinetic, like you can use domperidone. That is the most common. You give it as 10 milligrams 3 times a day, also for 2 weeks, and then onwards just proton pump inhibitors alone once daily. So basically, if you wrap everything in one, so that will be the management. That will be the management of upper GI bleeding if it is not a variceal bleeding. So that's all, folks, and I hope it was clear. And if you love more videos, what you have to do is you have to subscribe and like and click the bell icon so that you get notified whenever I post a new video. And I'll see you on another short video tutorial discussing another important topic. Until then, signing off, it's Ishfa.